Okay, this clinical presentation, this clinical this clinical presentation uh, and the chest x-ray of this patient, the clinical presentation and chest x-ray of this patient suggestive of pleural effusion with or without a lung mass. A pleural effusion is present when there is excess quantity of pleural fluid, when there is excess quantity of the pleural fluid in the pleural space. When pleural effusion is suspected or diagnosed, the first step is to determine the cause of the pleural effusion, and management starts with determining whether the fluid is transuded or exuded. Diagnostic thoracocentesis is the preliminary investigation of choice in the management of pleural effusion, except in patients with classic signs and symptoms of congestive heart failure when a trial of diuretic is warranted. Diagnostic thoracocentesis is a bedside minimally invasive procedure that permits fluid to be rapidly sampled, visualized, and examined microscopically and quantified. Pleural fluid analysis provides decision-making information in 90% of the cases. If a diagnostic thoracocentesis shows an exudative pleural fluid, further diagnostic investigation are indicated. Malignant pleural effusion is very likely in this patient who is a chronic smoker presenting with weight loss and pleural effusion. A CT scan the CT scan will most likely show a lung or mediastinal mass in this patient. Diagnostic thoracentesis would also determine the type of the pleural fluid. Transudative fluid would be rule out malignant diffusion and may also show malignant cells. Lung carcinoma, breast carcinoma, and lymphoma are three tumors that cause approximately 75% of all malignant pleural effusion. Okay, okay, it's occupational asthma. So this patient has respiratory symptoms and reversible airflow obstruction on spirometry at baseline. Findings consistent with asthma. Symptoms improve on sustained absence from the workplace, week-long conference, week-long conference. Symptoms improve on sustained absence from the workplace, week-long conference. This is the this is this key history element is suggestive. This key history element suggestive of occupational asthma, defined as asthma especially driven by workplace antigen exposure. Classic occupational antigen include animal protein, lab rodent workers, isocyanates, painters, and metals welders. Because of the long latency period, because of the long latency period required for immune sensitization, occupational asthma may not manifest for months to years. Initially, patients may link symptoms closely to the workplace. Eventually, when airway inflammation becomes stabilized and symptoms may persist at home throughout the work. Symptoms may persist even at home throughout the week and subside only after prolonged absence, vacations. Therefore, the diagnosis require detailed occupational history, careful symptom timeline, and two-step confirmatory test. First, asthma must be confirmed by reversible obstruction on spirometry for patient with normal baseline spirometry, bronchoprovocation, and performed to confirm bronchial hyperresponsiveness. Second, an occupational asthma is established by workplace specific worsening of airflow obstruction. These can be accomplished by a serial peak expirator flow rate measurement using a portable peak flow meter. Peak flow meter. Okay. Patients record their peak expirator flow rate at home and at work along with their symptoms. A peak expirator flow rate decline by more than 20% at the workplace related to at home is consistent with occupational asthma. Okay. Okay. This patient has TACO, transfusion associated circulatory overload. Transfusion associated circulatory overload, TACO, happen is a TACO is a reaction that occurs when a large volume of blood product rapidly transfused, fluid leading to fluid overload. Patients with cardiac and renal disorder as well as patient with cardiac and renal disorder as well as children aged less than 3 and patients aged more than 60 chronic asthma are at increased risk. For instance, toddler with severe chronic iron deficiency anemia due to excessive milk consumption more than 24 hours per day and poor intake of iron rich food are susceptible for to TACO, as seen in this patient. Symptoms of TACO develops within 6 hours of transfusion initiation and include respiratory distress, dyspnea, tachypnea, tachycardia, pulmonary edema. Signs of heart failure including S3 gallop, jugular venous distension may be present. Chest X-ray is often performed to confirm the pulmonary edema and exclude other cause of respiratory distress pneumothorax. Treatment includes respiratory support, supplemental oxygen, and diuresis with furosemide loop diuretics. In high-risk patient, preventive measures may include limiting transfusion volume, transfusing slowly, and administering pre-transfusion diuresis, pre-transfusion diuretics. Okay, is high. Respiratory, uh, respiratory acidosis. Is his AA gradient is normal? Like normal AA gradient is 5 to 15, isn't it? Age divided by 4 plus 4. Yesterday we did a question. Maybe I don't know. Maybe BMI is high. Yes, you have diagnosed right. Like it is obesity. Oh, yes, and obesity hypoventilation syndrome. Now, in like in alveolar hyperventilation, just think in the previous question we have found a question where the diagnosis was alveolar hypoventilation. On that question, AA gradient was normal. Can you remember that question? Look at right. Just search alveolar AA gradient. Then we may found the question. Okay. Yes. Hypoxia and hypoventilation. These two cause has normal AA gradient. And increased AA gradient has three cause like ventilation, perfusion mismatch, diffusion limitation, and left to right shunt. Right to left shunt. These three has increased AA gradient. Okay. Age divided by 4 plus 4. Right, like right in the Gemini, how to calculate the AA gradient. Have you watched Snow White, the recent Snow White movie? Yes. Okay. This is not the formula we have found. Just go below A gradient age, like what I have told you, write that. Then we may found. Look at this normal A gradient. Age in years by 4 plus 4. That I am talking about. So age in years, this patient has 45 years. So if we take 44, like 44 divided by 4 plus 4, then 15. Normal A gradient is 5 to 15. Yes, yes, that's why. Okay, not always correct, but it's like like Menzer index for diagnosing IDA and thalassemia. That one not always fits in the real life. In real life, that one does not fit always. Yes, I have found. Sorry, it helps for the questions, but in reality, not always fits. Okay, more than 13 is IDA and less than 13 is thalassemia. Managerial is 13. Okay. I always forget this part, like which one is. Okay. Okay. Uh, okay, I'm talking now explanation. Okay, obesity hypoventilation syndrome is defined as daytime hypercapnia PaCO2 more than 45 millimeter of mercury, PaCO2 more than 45 millimeter of mercury in a obese patient, and BMI is more than 30 and often more than 40 kg per meter square. I should do this. I may have this. Okay, without another explanation. I have some problem because I fall asleep while talking, and you have found in multiple times. Sorry. Yes. Okay. Without another explanation for the, I look like little elephant. Okay. Next, without another explanation for the hypercapnia, most patients have coexisting obstructive sleep apnea with frequent apneic events and daytime hypersomnolence. Other features of obesity hyperventilation syndrome include dyspnea, polycythemia, respiratory acidosis with compensated metabolic alkalosis, pulmonary hypertension, and core pulmonary. Severe mechanisms likely contribute to hypoventilation and resulting hypercapnia. Obesity reduces the obesity reduces chest wall and lung compliance, leading to decrease in tidal volume and total lung capacity, and an increase in airway resistance. As a result, higher levels of ventilatory drive are required to maintain normocapnia. But there is an inability to exhale excess carbon dioxide, result higher levels of excess carbon dioxide during the day during persistent restriction. These leads to carbon dioxide accumulation overnight with subsequent chronic respiratory acidosis. Renal bicarbonate excretion. Renal bicarbonate excretion is decreased as a compensatory mechanism that blunts the ventilatory response to the increased CO2 and contributes to hypoventilation. In some in some patients with obesity hypoventilation syndrome cannot breathe due to excess weight and altered lung mechanics, and won't breathe due to decreased chemosensitivity to hypercapnia from persistent nocturnal hypoventilation. Okay, look at the box. Obesity hypoventilation syndrome. Obesity with BMI 30 or more than 30 kg per meter square. Awake daily hypercapnia PaCO2 more than 45 millimeter of mercury. No alternate cause of hypoventilation. Workup ABG on room air hypercapnia, normal A gradient. No restriction pulmonary disease on chest X-ray. Restrictive pattern of pulmonary function test. Normal TSH. Polysomnography. Treatment nocturnal positive pressure ventilation as first line therapy, weight loss, bariatric surgery in select cases, avoidance of sedative medication, respiratory stimulants, acetazolamide as last resort. Acetazolamide as last resort. Okay. Okay, it's asthma in pregnancy. These patients' intermittent cough, chest tightness, and shortness of breath, worse at night, are hallmark of symptoms of asthma. Asthma is the most common pulmonary disorder encountered during pregnancy. Roughly one third of the cases improve, one third are stable, one third are worsen. Patients with a history of severe or poorly controlled asthma are prone to developing unstable disease. Patient unstable disease during pregnancy, typically worsening in the second trimester. The immunologic and endocrine changes during pregnancy can also rekindle previously unresolved without resolved childhood asthma. Asthma presents similarly in pregnant and non-pregnant patients. Cough, wheezing, dyspnea, chest tightness, and symptoms are typically intermittent and may be exacerbated by weather changes, especially cold, allergens, infections, or exercise. They usually worsen at night and potentially due to circadian hormonal variation, low epinephrine glucocorticoid signaling causing reduced anti-inflammatory effect, or to environmental factors, dust mites, or pet hair in mattress. Wheezing may be absent outside of acute attack. Asthma control is essential for avoiding maternal and fetal complications. Preterm delivery, low birth weight, antenatal hypoxia. Most therapies are safe and generally involve inhaled short-acting beta agonist albuterol for acute symptoms. Inhaled corticosteroids are required for persistent asthma. Oral corticosteroid prednisolone may be required for acute exacerbation. Gestational asthma can be confused with dyspnea of pregnancy, a common physiologic cause of shortness of breath, likely due to progesterone-induced stimulation of the medullary respiratory center. Although it worsens during the second trimester, dyspnea of pregnancy is persistent rather than intermittent, not associated with diurnal variation. It would not explain this patient's cough and chest tightness. Next, he has noisy breathing, present upright, super, improves when sleeps, back is arched, neck is extended. Is he has epiglottitis? His back is arched, neck is extended, patient frequent diapers. He pauses frequently while breastfeeding to catch breath. And no, it's not GERD. It's B, vascular ring. Okay, vascular. Okay. This infant, this infant with feeding difficulty biphasic stridor has tracheal indentation on X-ray. Oh, oh. Where is biphasic? Okay, that one is important. Okay, this patient with feeding difficulty and biphasic stridor, likely biphasic stridor has tracheal indentation on X-ray suggestive of extrinsic airway compression. These findings most likely due to a vascular ring, a congenital malformation of the aortic arch, a common vascular ring, most commonly a double aortic arch, most a common vascular ring, most commonly a double aortic arch encircle and encompasses the trachea and the esophagus, causing respiratory and GI symptoms beginning in early infancy. Biphasic stridor due to tracheal narrowing is Biphasic stridor due to tracheal narrowing is classic and improves with neck extension and back arching. These maneuver help relieve extensive airway compression, poor weight gain, extensive airway compression. Poor weight gain can result from increased work of breathing during feeds and in addition to feeding difficulty caused by esophageal compression vomiting. Chest X-ray is often the first step in evaluation, and patients with a double or aortic arch typically have right-sided tracheal indentation at T3 to T4. Diagnosis is made using CT or MR angiography of the chest, which reveals the abnormal aortic vasculature. Echocardiography is performed. Echocardiography is also performed to evaluate for intracardiac anomalies, ventricular septal defect, and a common comorbidity. Okay. Think about the side effect of the beta agonist. Okay, this patient with wheezing, respiratory distress. This patient with wheezing, respiratory distress has an acute asthma exacerbation likely precipitated by exposure to cleaning chemicals that has been managed with inhaled beta-2 agonist albuterol and systemic corticosteroid methylprednisolone. A new onset symptom weakness, a muscle weakness, is most likely the adverse effect of the albuterol. Albuterol is usually safe. However, receiving high dose of inhaled albuterol are at risk for clinically significant hypokalemia because beta-2 agonists driven potassium into the cell via stimulation of sodium potassium ATPase pump. Manifestation of hypokalemia include decreased tendon reflex and muscle weakness as seen in this patient. ECG changes and potentially fatal arrhythmias, ventricular fibrillation can occur. Additional adverse effects of beta-2 agonists include tremor, tachycardia, headache. The next step of this patient is to order an serum electrolyte panel to confirm and assess the severity of hypokalemia. An ECG should be obtained to evaluate for life-threatening cardiac complication. Potassium replacement therapy is warranted for symptomatic hypokalemia. Okay. Yes. Hypokalemia, diuretic therapy, thiazide diuretics, vomiting and diarrhea, hypomagnesemia, hyperaldosteronism, increased beta-2 adrenergic activity, albuterol, muscle weakness and cramps, hyporeflexia, rhabdomyolysis, and cardiac palpitation, arrhythmia, broad, flat T-wave, flat T-wave, prominent T-wave, and potassium replacement. Okay. Okay, it's this patient with tachypnea, hypoxia, and a segment of the chest wall that moves, a segment of the chest wall that moves inward during inspiration, inspiration most likely has flail chest. Flail chest occurs when fractures. Flail chest occurs when fracture of three or more than three contiguous ribs in two different locations creates an isolated chest wall segment, flail segment, that moves paradoxically opposite to the rest of the rib cage during respiration. Typically, the extreme trauma, typically the extreme trauma to the chest wall that creates the flail segment also contuses the underlying lung, causing diminished anterior breath sound beneath these patients' anterior flail segment. Flail chest negatively impacts respiration and oxygenation in multiple ways, including the following: impaired generation of the negative intrathoracic pressure during inspiration, and increased dead space during expiration causes ineffective ventilation, pulmonary contusion with alveolar hemorrhage and edema in underlying lung, pulmonary contusion with alveolar hemorrhage and edema in the underlying lung impedes oxygen diffusion. Fracture related pain causes respiratory splinting, decreased respiratory effort, and bivascular atelectasis. Flail chest often results in respiratory failure, requiring mechanical positive ventilation, which, due to positive pressure, can force the flail segment to move outward with the rest of the rib cage during inspiration. Okay, yes. Injury to the tracheobronchial tree can cause extensive air leakage into the mediastinum and pleural space and can result in pneumothorax. This can result in pneumothorax, often tension pneumothorax. Massive pneumothorax or hemothorax can increase the intrapleural pressure, compress the lung, prevent adequate ventilation, leading to hypoxia. However, such a large intrapleural collection of air or blood typically causes diffusely diminished or absent breath sound or tracheal deviation from mass effect. These patients' breath sounds are only diminished anteriorly in the lung underlying the flail segment, pulmonary contusion with uh, and his trachea is in midline. Okay. Cigarette smoking is the single greatest risk factor for lung cancer because Early diagnosis reduces lung cancer morbidity and mortality. Annual screening with a low-dose CT scan is recommended who have for those who have more than 20 pack years. Those who have smoked more than 20 pack years. Screening should begin at age 50. Screening should begin at age 50 and continue to age 80 or until 15 or more than 15 years of smoking cessation is achieved. Screening is therefore indicated for patient age 56, 42-year back history. Okay, we'll start like doing low dose CT scan for patient with cigarette smoking. We do this investigation for screening purpose for early diagnosis. Okay, like for early diagnosis of the lung cancer, we can do this screening like low dose CT scan of the chest. The patient who is smoker and recommended interval is yearly. So and screening should age of screening is 50 to 80. So lots of time they have to do this screening if we do it properly. Yearly and eligibility is more than 20 pack year of history and currently smoking or quit smoking within past 15 years. Okay. Albumin is normal, bilirubin normal. Alphos is normal, isn't it? Everything is normal. Yes, don't think so. It's look like alpha 1 antitrypsin comes with lungs and liver. Where is the liver? Yes, not that high. Is it significant? Okay. Okay, so this young patient with chronic dyspnea on exertion, decreased breath sound, slight liver function test, abnormality and a family history of cirrhosis, likely has alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is a codominant alpha-1 antitrypsin deficiency, a codominant genetic disease present similarly to other forms of COPD or with chronic obstructive chronic productive cough, dyspnea, wheezing, and recurrent respiratory infections. On an average, a smoker presents in their 30s and a decade earlier than non-smoker. Alpha-1 antitrypsin deficiency can also affect the liver, neonatal hepatitis, hepatocellular carcinoma, and skin panniculitis. Patients with liver disease may be asymptomatic to up until the point of end-stage disease, and cirrhosis is the second most common cause of death in this patient. Alpha-1 antitrypsin deficiency should be considered in a number of situations, including patients with COPD at a young age, COPD less than 45, COPD with minimal or no history of smoking, or a family history of emphysema or liver disease. Diagnosis is confirmed by serum alpha-1 antitrypsin level and should also include primary pulmonary function test. Treatment includes IV supplementation with human alpha-1 antitrypsin in addition to bronchodilator and corticosteroid as needed. Individuals with severe lung disease are candidates for lung transplantation, whereas those with hepatic failure can be treated with liver transplantation. Okay. No, why you are thinking deep vein thrombosis? May not be. He has sickle cell disease. Sickle cell disease with a chest problem, like there is a called acute chest syndrome. There is a saying. Okay. This patient with sickle cell disease but has acute chest syndrome, a life-threatening complication presents with mm, new density new pulmonary density along with fever, respiratory symptoms, hypoxia, chest pain. The pathophysiology of acute chest syndrome involves vasoocclusion of the pulmonary microvasculature, which occurs due to increased hemoglobin polymerization and red blood cell sickling in the setting of pulmonary inflammation or alveolar hypoxia. Microvascular occlusion leads to localized ischemia and endothelial injury. The most common inciting event in adults in acute vaso-occlusive pain, as seen in this patient who sought care for limb pain and has a low hemoglobin level. Reticulocytosis bone pain, which occurs when sickle RBC occlude bone marrow vessels, can precipitate acute chest syndrome through the following mechanism: fat embolism, inflammation, ischemia, necrosis of the bone marrow can cause fragmentation and embolization of the bone marrow fat into the circulation and pulmonary vasculature. Free fatty acid from the embolus and pro-inflammatory and worsens vaso-occlusion. Thrombocytopenia is often seen with fat embolism, hypoventilation, splinting from pain and opioid therapy. Constricted pupil can lead to hypoventilation and atelectasis. The resulting ventilation perfusion mismatch causes hypoxemia, further promoting sickling. In addition to acute vaso-occlusive pain, other chest syndrome triggers, particularly in children, which includes asthma exacerbation and infection. Pneumonia is usually caused by atypical bacteria, chlamydia, mycoplasma, and streptococcus pneumoniae, not staph aureus, is associated with leukocytosis. Okay, yes. Pulmonary venous congestion from fluid overload. Pulmonary venous congestion from fluid overload can cause dyspnea and hypoxia. However, jugular venous distension and possibly peripheral edema uh, is typical, and chest X-ray would reveal peribronchial coughing. In bilateral pulmonary edema, there is peribronchial coughing, prominent pulmonary vascular markings, and a patchy perihilar opacity. Moreover, this patient has relatively low positive balance given her adequate urine output plus insensible losses. Okay. How? CTs can show edema in the gluteal and subcutaneous tissue with free gas. CTs can show edema and gluteal. In the gluteal region, there is like of gas accumulation. Yes, they are asking for the IV fluid antibiotic given the patient undergoes surgical debridement and then several hours after that there is dyspnea. And yes, is it like dyspnea happens due to hypoventilation, or is it due to VQ mismatch, diffusion limitation? Oh wait, is it pulmonary embolism? Like after a surgery there is sudden severe shortness of breath. Not sometimes there may be normal extras. Ill filtrate can happen. Maybe creatinine is high. Yes. May uh, it is otherwise. Think about not really. It may be ARDS. No, diffuse pulmonary edema does not correct function. Okay, this is tough. Just after surgery, there is bilateral. So after surgery, bilateral pulmonary edema, like uh, ARDS. So this patient with hypoxemia and bilateral lung infiltrate. This patient with hypoxemia and bilateral lung infiltrate likely has ARDS. ARDS due to sepsis from necrotizing fasciitis. ARDS involves an inflammatory response. ARDS involves an inflammatory response that leads to pulmonary leakage and diffuse pulmonary edema. Fluid from pulmonary edema fills the alveoli. Fluid from pulmonary edema fills the alveoli and facilitates alveolar collapse. Alveolar ventilation V is zero, which results in extreme ventilation perfusion mismatch, right to left intrapulmonary shunting, causing hypoxemia. Because diffuse bilateral, because diffuse pulmonary edema prevents air from reaching the alveoli throughout much of the lungs, more than 50%, an increase in the FiO2 does not correct the hypoxemia. Increased AA gradient is another characteristics of pulmonary edema, as with any process cause VQ mismatch or impaired diffusion across the AA membrane. Finally, pulmonary edema also leads to fluid collection within the lung interstitium, resulting in stiffening of the lungs, decreased lung compliance. In contrast to hypoxemia due to diffuse pulmonary edema, hypoxemia due to localized intrapulmonary shunting, lobar pneumonia, atelectasis, basilar pulmonary edema typically does not correct with increased FiO2 because only a portion of the lungs is affected and the normally ventilated alveoli compensate via increased oxygen transfer. Okay, yes, ARDS does not resolve with oxygen. Okay, do you want me to read the box? Okay, reduced, like hypoxia, inspired oxygen is low, reduced PiO2. It may be due to high altitude, and hypoventilation happens due to CNS depression or morbid obesity. In these two cases, AA gradient is normal, and supplemental oxygen actually corrects the condition, like high altitude and hypoventilation corrects with oxygen. But in diffusion limitation, diffusion limitation is emphysema and ILD, increase AA gradient, and it does not correct with supplemental oxygen. It does not correct with supplemental oxygen. PQ mismatch, small pulmonary embolism, lobar pneumonia, AA gradient is increased. AA gradient is increased and it corrects with supplemental oxygen. And large intrapulmonary shunt, large dead space ventilation. Large intrapulmonary shunt example is diffuse pulmonary edema where AA gradient is increased. Large intrapulmonary shunt AA gradient is increased and it does not correct with supplemental oxygen. And large dead space ventilation like massive pulmonary embolism, right to left intracardiac shunting, it does not correct with supplemental oxygen. Okay, only VQ mismatch corrects the VQ mismatch diffusion limitation corrects with oxygen. VD. Okay, one plus. It fits with vasculitis. EGP, granulomatosis with polyangiitis. Granulomatosis with polyangiitis has, yes, lungs and kidneys, and there is rhinosinusitis too. So upper respiratory tract, lower respiratory tract, and kidneys. These patients, intermittent fever, malaise, weight loss, are most likely manifestations of granulomatosis with polyangiitis. GPA is a vasculitis of small and medium vessels that most commonly affects middle-sized and older white men and women. Common manifestations include upper respiratory tract, most common site of involvement chronic rhinosinusitis, nasal ulcer, saddle nose deformity, hearing loss, lower respiratory tract tracheal narrowing with ulceration, highly characteristics of GPA, lung nodules with cavitation, fibrotic interstitial lung disease, and alveolar opacities and hemorrhage, and kidneys, elevated creatinine, 85% of cases, necrotizing crescentic pause-immune granulomato pause-immune glomerulonephritis may be rapidly progressive with high risk kidney failure. Patients also commonly have anemia of chronic disease. Diagnosis of GPA is made with anti-neutrophil cytoplasmic antibody, and definitely with tissue biopsy showing capillaries or granulomatous inflammation. Treatment involves high dose corticosteroid as well as cyclophosphamide or rituximab. Okay, yes. Pulmonary aspergillosis. Pulmonary aspergillosis most commonly occurs in patients with immunosuppression or structural lung defect, neither of which is present in this patient. Cavitary lung disease can sometimes present. Cavitary lung disease can sometimes occur in immunocompetent patients, but aspergillosis would not explain the tracheal deformity and renal insufficiency. And sarcoidosis commonly causes non-causating granulomatous inflammation in the lungs. It typically appears as bilateral hilar adenopathy rather than tracheal ulceration and cavitary lesions. Kidney involvement can occur but is usually associated with hypercalcemia. Next. Yes, yes, obviously.